Assalamualaikum everyone. We are group 14 and for this seminar we're going to present and discuss a little bit about Botox for orofacial pain. This is our table of content. In this presentation we're going to touch a little bit about orofacial pain, Botox, and how Botox are used for orofacial pain and some case studies related to Botox.
Facial pain is defined by pain that originates from oral structures accompanied by facial pain. Facial pain is classified into somatic pain, neuropathic pain, and psychogenic pain. Somatic pain occurs in response to nauseous input. Neuropathic pain is generated within the nervous system itself. Meanwhile, for the psychogenic pain, is pain that lacks an adequate source of nauseous input. The summary of classification of orofacial pain. Signs and symptoms of orofacial pain are headache, pain behind eyes, discomfort, inability to open smoothly, limited opening of mouth, swallowing difficulties, neck problems, jaw problems, and ear problems. Pain can be managed by education of patient and explanation, self-care, thermotherapy, intraoral appliance, and pharmacotherapy. For the pharmacotherapy, we can give NSAID, muscle relaxant drug, Botox injection, and trigger point block therapies, which using LA in combination with corticosteroid.
Botox is defined by Oxford Dictionary as a drug prepared from botulinum or botulinum toxin that is used medically to treat certain muscular conditions and cosmetically to remove wrinkles by temporarily paralyzing facial muscles. This botulinum toxin is a neurotoxin produced by bacteria Clostridium botulinum. Botox has a remarkable history. A German physician and poet, Justinus Kerner, first developed the idea of a possible therapeutic use of botulinum toxin, in which he called sausage poison. In 1895, Professor Emil was the first to isolate the bacterium Clostridium botulinum following a botulism outbreak in Belgium. In 1928, Dr. Hermann Sommer at the University of California, San Francisco, first isolated in purified form botulinum toxin as a stable acid precipitate. However, it took 20 years before the botulinum toxin was finally isolated in crystalline form by Dr. Edward. In 1970s, scientists started using botulinum toxin to treat strabismus, also known as cross-eyed. The researchers noticed that botulinum toxin reduced wrinkles in the glabella while they were testing this treatment on monkeys. After botulinum toxin proved successful in the treatment of strabismus, Allergan licensed the treatment and branded it Botox. Botox then started to get approval from FDA for a variety of medical and cosmetic uses. After getting FDA approval, Botox was then used in a variety of conditions, firstly strabismus, blepharospasm, and hemifacial spasm in 1989, cervical dystonia in 2000, glabellar lines in 2002, axillary hyperhidrosis in 2004, chronic migraines, upper lip spasticity, spasticity in the flexor muscle of the elbow, wrist, and fingers in adults with stroke, traumatic brain injury, or the progression of multiple sclerosis in 2010, urinary incontinence in 2011, crow's feet in 2013.
So first thing first,
when Botox started to be used in treatment of orofacial pain. Since 1989, Botox has been used for medical treatments but has been recently become a popular innovative dental treatment option. Botox was approved by the US Food and Drugs Administration, which is FDA, for the treatment of strabismus, blepharospasm, hemifacial spasm, facial glabellar lines, cervical dystonia, and axillary hyperhidrosis. Since then, Botox has been used for the treatment of various disorders in the orofacial region to help treat the primary and secondary masticatory and facial muscle spasm, severe bruxism, facial tics, orofacial dyskinesia, dystonia, and even idiopathic hypertrophy of the masticatory muscles. Over the past several years, Botox has been increasingly utilized as an adjuvant treatment for the head and neck pain, such as tension-type headaches and migraine headaches. So what are the types of Botox used in treating orofacial pain? For your information, there are 7 distinct serotypes of botulinum toxin, which are type A, type B, C, D, E, F, and G, which differ in their potency, duration of action, and cellular target sites. The commercially available variants are botulinum toxin type A and type B. As for type A, it is the most commonly used toxin in medicine and dentistry. It is commercially available and approved by the FDA for the human use. Type A is the most popular as there is less pain associated with the injection and also has a slower onset of action with a longer paralysis. As for type B, it is used in cases of resistance to type A and only approved for the use in cases of cervical dystonia, which is a rare neurological disorder characterized by involuntary muscle contraction in the neck that cause the abnormal movement and posture of the neck and head. Botulinum type A is marketed worldwide under the name Botox, Dysport, and Porcine, while type B is marketed as Myoblock and Neuroblock. Now we proceed to the mechanism of action of botulinum toxin. So first, botulinum toxin is known to cause muscular paralysis by its action on the neuromuscular junction, where it blocks the acetylcholine release in the cholinergic neuron synapse. Following the injection of botulinum toxin, its heavy chain binds to the presynaptic cholinergic motor nerve terminals in the neuromuscular junction, and then it is internalized into the neuron by endocytosis. Toxin is cleaved by the internal proteolytic enzyme, and the degradation by products interferes with the normal process of vesicle fusion to the plasma membrane. This causes the inhibition of the exocytosis of acetylcholine, leading to blockage of acetylcholine release from the presynaptic nerve terminals in the neuromuscular junction and inhibit the depolarization of postsynaptic nerve terminals. So this is another figure about the mechanism of action of botulinum toxin. Basically, the light chain of botulinum toxin cleave the SNAP25, which is the protein, and consequently prevents the release of acetylcholine into the neuromuscular junction. Toxin inhibits the release of acetylcholine from the presynaptic nerve terminals effectively and will either reduce the intensity of the contraction of muscle or will eliminate the contraction altogether depending on the dosage used. Essentially, Botox interrupts the contraction process of the muscle and thus causes a temporary muscle paralysis which lasts up to 3 months. The action of Botox is irreversible, occurs within 1 to 14 days, peaks at approximately 4 weeks, and begins wearing off after 10 to 12 weeks. Gradually, the muscle returns to its full function and with no side effects as the muscle initiates new acetylcholine receptors and the growth of branches from the neurons to form new synaptic contacts. The toxin also has been shown to block the acetylcholine release at parasympathetic nerve terminals. The clinical effect appears between 1 to 3 days after administration of the Botox, and the maximum effects occur after 1 to 2 weeks, which then stabilize to a moderate level until complete recovery of the nerve in approximately 3 months. Botox does not inhibit the production of acetylcholine, and therefore, motor function is recovered by subsequent motor axon outgrowth. Botox can be applied clinically in the orofacial disorders such as temporomandibular disorders or TMD, also include wide range of disturbance associated with the function of masticatory system. Second one is bruxism, masseter muscle hypertrophy, myofascial pain, mandibular spasm, oromandibular dystonia, which also TMJ dislocation can be caused by OMD, pain in the head and neck, and trigeminal neuralgia.
So for the next SLO, Junaidah and I are going to discuss some case studies related to Botox used in orofacial pain treatment. When an unspecified facial pain persists, various treatments ranging from conservative physical therapy and medication to surgical treatment can be applied. Conservative treatments usually include medication, physical therapy, and splint therapy. For medication, it is primarily used to treat various facial pains such as unspecified TMJ disorders and neuropathic pain. The drugs used include NSAIDs, analgesics, antidepressants, sedatives, muscle relaxants, and steroids. While physiotherapy includes thermotherapy, cooling therapy, laser therapy, and electrical stimulation therapy. Of this, low-level laser therapy is the easiest to apply and produces no pain or discomfort. The laser has various effects such as improvement of vasodilation and blood circulation due to increase of temperature, relief of pain, relaxation of muscles, waste removal, and calming of the sensory nerve. And if conservative treatment fails, surgical treatment can be used, but the burden associated with invasive surgery and the risk of complication will increase. And in such cases, botulinum toxin can be a very useful therapy. So we have prepared 4 cases for you guys. And the first case is a 67-year-old woman who visited a university hospital in Seoul. She complained of severe pain in the maxillary left anterior buccal vestibule and also reported that her upper lid has tightened after multiple dental implants were placed in her maxilla. Clinically and radiologically, painful traumatic trigeminal neuropathy was diagnosed. So the medications and treatment that were given to her include Tegretol, amitriptyline, a stent for her maxilla, Neurontin, electric acupuncture stimulation therapy, and Trilactol. However, the medication and treatment can only either slightly help alleviate the symptoms or worsen the pain. Although there was slight improvement seen from her symptoms, she still complained of persistent pain. So finally, her doctor decided to inject Dysport, which is botulinum toxin A or Botox, on the upper part of her mucosa. Although there was a transient side effect where food was spilled due to the unnatural movement of her lips during mealtime, the pain was significantly reduced. 3 months later, the second injection of Dysport was performed, and thereafter the pain was alleviated and the treatment was finally terminated. For the second case, a 52-year-old woman was referred to an oral and maxillofacial surgeon because of intermittent severe pain in the left facial area after facial nerve reconstruction during plastic surgery, and during examination, the patient complained of general stiff pain in the facial region, including the left zygoma, masseter, and temporomandibular joint area. There were also symptoms of excessive salivation in the left cheek, and the patient was diagnosed with painful traumatic trigeminal neuropathy. The medication and treatment that was given to this lady include trilactal and physical therapy. However, none of these two actually help improve the pain. So again, the doctor decided to inject inotox, which is botulinum toxin A, into her left masseter. 2 weeks after the first injection, the pain was significantly reduced. However, it still persists in certain areas. So 6 months later, the second injection was performed with the same dose. After the second injection, almost all the pain was alleviated, but she still complained of pain in certain areas. So the doctor decided to give her another injection 3 months later, and after this third injection, the pain was markedly reduced to a tolerable level for her.
Hi and Assalamualaikum. I'm Junaidah and I will continue the case studies that using Botox for the management of orofacial pain. So the first case study is a 60-year-old female patient presented at the University of Minnesota TMD and orofacial pain clinic with a 7-year history of persistent dentoalveolar pain disorder in the distribution of the right maxillary and mandibular branches of the trigeminal nerve. Her pain occurred mostly within the deep tissues involving the vestibular mucosa apical to the right maxillary teeth, the right maxillary sinus region, and dentoalveolar region of the right mandibular second premolar, which had been endodontically treated. She described the pain as a daily constant at an average intensity of 4 to 5 on a 0 to 10 numerical rating scale with 5 to 10 sharp episodes per day, rated as 8 out of 10 in intensity and duration of approximately 1 minute each. Prior treatments included multiple root canal treatments that were unsuccessful in relieving her pain. Her medical history included rheumatoid arthritis, chronic regional pain syndrome of the right foot, neck and back pain, as well as chronic sinusitis that had been previously surgically treated. So this is the key points, which is a 60-year-old female patient come with a chief complaint of persistent dentoalveolar pain at the right mandibular second premolar, which started 7 years ago. And the pain is constant and sometimes came with a sharp pain. And it radiates to the right maxillary and mandibular branches of trigeminal nerve and occurred mostly within the deep tissues involving the vestibular mucosa apical to the right maxillary teeth, the right maxillary sinus region, and dentoalveolar region of the right mandibular second premolar, which had been endodontically treated. So it is constant at an average intensity of 4 to 5 over 10, with sometimes 5 to 10 sharp episodes per day that about 1 minute each, that she rated it as 8 over 10 of pain scale. As for her past medical history, she has rheumatoid arthritis, chronic regional pain syndrome of the right foot, neck and back pain, and also chronic sinusitis. And drug history for her dentoalveolar pain, she had been prescribed with pregabalin 25 mg for 3 times daily, and pregabalin medication is used to treat neuropathic pain. Second is topiramate 25 mg 3 times daily, and topiramate is one type of anticonvulsant, and she also had been prescribed with Stern Health topical application of a compound medication which are composed of 10% gabapentin, 2% lidocaine, 2% tetracaine in an oral adhesive paste. She reported that her symptoms is reduced after using this medication, especially in the spread of her pain, which become more localized to the intraoral sites. However, the pain continued to occur daily and was constant at the same level of intensity, which is about 5/10 of pain scale. And the patient denied using any additional analgesic. At first, the dentist actually did a local anesthetic block of the right mandibular second premolar and at the right nasopalatine block. However, it only gives a temporary pain relief. So, in this case, the dentist decided to give botulinum toxin in addition to her current medication regimen. And 100 units of botulinum toxin A were diluted in 0.3 milliliter of 2% lidocaine without vasoconstrictor. So there is a total of 6 submucosal injection of 0.05 milliliter, about 1 millimeter depth, corresponding to approximately 17 units of toxin per injection site. So 3 of the injection were given at the posterior vestibular sulcus of the right maxillary molar region, and the other 3 was given at the attached gingiva around the right mandibular second premolar, which is 2 was given at the buccal and 1 was given at the lingual. After 3 months, patient reported a reduction in pain intensity from 5 out of 10 to 2/10, which had started about 1 to 2 weeks after the injections. And the pain intensity was maintained for about 2 months. However, the pain gradually returned to its baseline, which is 5/10. And patient also reported having side effects such as dryness in the area of injection with consequent foot impacting and facial asymmetry, which she described as drooping of her smile on the ipsilateral side of the injections. But the patient significantly perceived the benefit of the botulinum toxin A, so she requested to repeat the procedure after 3 and 6 months. But the results were similar in magnitude and duration after the second and the third injection. So at 9 months follow-ups after the first set of injection, the patient reported being pain-free for about 3 months while maintaining the same medication regimen. Next, for the case study 2, a 61-year-old female patient presented at the University of Minnesota TMD and Orofacial Pain Clinic with a 3-year history of trigeminal neuralgia in the distribution of the left maxillary branch of the trigeminal nerve. She described the pain as an electric shock with a 10 out of 10 intensity lasting for seconds. She reported having multiple pain episodes per day, which happened spontaneously or triggered by cold wind or water in her face, eating or brushing her teeth. Prior treatments included carbamazepine, but she reported having hot flashes as a side effect and could not tolerate it. The pain had also not been adequately managed with other anticonvulsants, antidepressants, and opioids. Medical history included significant anxiety despite considerable treatment efforts. And as for the key points, this is a 61-year-old female patient came with a chief complaint of pain at the left side of her face and mouth. It is a sharp pain which started 3 years ago that radiates to the left maxillary branch of the trigeminal nerve, which occur between the left infraorbital region and the left ala of her nose, and in the buccal gingiva apical to the left premolar region, extending over a partially edentulous ridge posterior to the second premolar. And the pain intensity lasts for seconds, which happens sometimes spontaneously or triggered by cold wind, water in her face, eating or brushing her teeth. And the pain scale is 10 out of 10. She also has anxiety, and she had been prescribed with carbamazepine and other anticonvulsants, antidepressants, and opioids for the management of her pain. As an initial approach, the drug was switched to oxcarbazepine, titrating up to 600 mg twice daily, as patient reported having hot flashes as side effect after consuming carbamazepine. So the oxcarbazepine dose was gradually increased to 100 to 2,400 mg twice daily over follow-up visits during a period of 6 months. The patient reported having improved pain control. However, she continued to experience daily pain episodes as well as periods of severe exacerbation of her symptoms. So, multiple medication were tried as add-on therapy of pregabalin and also baclofen, and potentially decreasing the dose of oxcarbazepine. Even though the starting dose was small, but the patient reported having excessive sedation and inability to function. She also did not want to try other oral medication because of the side effects and would not consider any surgical treatment. So this is where the long-acting topical application of onabotulinum toxin A was elected in addition to her current dose of oxcarbazepine. During the treatment, patient had recognized two clear trigger areas for her pain, at which first trigger was at the extraoral location between the left infraorbital region and the left ala of her nose, where pain was triggered by light touch and contact with water. And second trigger area was the intraoral location in the buccal gingiva apical to the left premolar region, extending over a partially edentulous ridge posterior to the second premolar, where her pain was triggered mainly while eating. For her extraoral trigger, a total of 100 units of onabotulinum toxin A were diluted in 0.2 ml of 2% lidocaine without vasoconstrictor was given. A total 4 subcutaneous injection of 0.05 ml about 1 mm depth were performed. The injections were given in a triangular distribution covering the extraoral trigger area. And as for her intraoral trigger, the injection sites covered the trigger region reported by the patient, including the buccal palatine gingiva apical to the left maxillary canine, the buccal gingiva apical to the left first premolar, and the attached gingiva on the edentulous ridge posterior to the first premolar. After 3 months, patient reported having continued total relief in the extraoral trigger areas and moderate improvement in the intraoral trigger areas. And the pain intensity also reduced to 3/10, and the frequency of pain episodes also reduced. The patient also reported having drooping of her smile to the left side as a side effect, and patient denied any dryness in the injection area. The extraoral and intraoral injection were performed again using the same procedure and dose. And after 6 months, the result was same as before, but there is a change in the location of the intraoral triggers. The pain has been subsided in the palatine region of the left, and a new trigger area was identified, which is at the posterior to the first premolar, apical to the edentulous ridge in the region of the second premolar. So the same dose of the botulinum toxin was injected with a similar technique at the new trigger area. So this is our references, and with that, thank you.